All right, so we will begin. Okay, so there's two groups of people on the phone. So I'm going to go ahead and stop my video so you don't have to see my face up front and personal. Okay, so there's two types of students on the phone today. Those that are certified and those that are not certified. So the training is going over the highlights of what you need to remember and some helpful hints on test taking for the CPC exam. There's a group of people on this call that will be taking the exam on the 16th of December. So those of you that are certified can think about them and have good thoughts about what they will be going through since you've been going through them. You had gone through that before. So I want you to go ahead and sit back and relax. We're going to take the knowledge you already have and look at some test techniques on multiple choice processing, time management, and of course, marking your books. You might be a little rusty in some areas, and so we're going to refresh your memory on those as well. So the first thing is let's talk about process of elimination. Especially in long scenarios, you'll want to look at the answers first, or you want to look at the answers, you want to look at the question first. And are there any instructions or key things that are noted there, like guidelines that you're going to have to look up or try to remember? Guideline questions are a little different than a coding question. Typically, there are two answers that don't make sense. And so we always advocate that you look at what your answer is. And in the case of a long scenario, you want to look at the question. Because some of the questions may outline a patient's whole hospital stay. And then your question is about day 5. So if you know in your mind already that day 5 is what you're going to be answering, when you get to day 5, you'll probably underline some key things there so that you know that's the spot you need to go to find your answer. Or else you're going to have to read the question again. So just another time-saving technique. You have only 2 minutes per question. And so the suggestion is to mark the difficult questions and come back to them later. Either in your booklet, you put a little flag there for the ones that you want to go back to if you have time. And then there's no set way that you need to take the exam. So you can take a few seconds and look through. Maybe you want to do the cases first. And the idea is that you want to do the quick questions first if you possibly can. But that can backfire because if you're reading the whole question and then deciding you don't want to answer it, you're going to read that question again. So I know that whenever I've taken tests, I've just start from the beginning and go for it. One time I did start in the middle and then went back, but you don't want to be jumping around. So you need to be able to strategize as to how you're going to take this test. And I'm sure you've taken practice tests so that you are more or less prepared on what you're going to do. In regard to marking your books, you can have anything written in your books. And you should have notes. In my books, I have notes for things that I've looked up already in my regular work life. Notes that how to code something, real quick notes, but the notes really need to be brief. They're there to jog your memory. They're not there to recite the whole section of something. You're going to spend a lot of time looking up notes and having to read those if you don't put them in a good place as well. So you want to make sure that you're organized and remember where all your things are. So these notes are going to be in ICD-10. These types of notes are going to be in CPT. these type of notes are going to be in HCPCS. And then you would mark those pages to make it easier for you to find them. But you can have anything marked in your book, anything, and written. The only thing you can't have are things pasted in the books. So you can't copy a page and then paste it in a blank page, or put a big note on a Post-it note and put it in your book. Okay. We're going to begin. One of the things that I'll indicate, if you have a question, put it in the chat box. And at the very, very end, hopefully we'll have time for questions. I do have a hard stop at 2:00. And you're probably looking at your clock, oh my gosh, 2:00, that's a long way away. So I do have a hard stop, but if you have questions afterwards, I'll definitely call you and help you out, not a problem. Another thing is, don't spend time, there's going to be some scenarios, I'm going to have you code. Don't spend time copying the questions down or taking pictures, or I want you to be present. I want you to do the work. I want you to listen. I want you to read. If you're spending time trying to take the picture and you're going to lose the idea of what you're learning. I will send anybody that wants the question list that I'm presenting to you. So hopefully everybody can relax about that. All the questions that we'll be working through, I am more than glad to send those to you. And I will. And that way you won't have to spend the time writing the question down or taking pictures of the question. That'll make it easier for you to actually participate and be involved. All right, so the test is separated into different chapters and sections. And so the first section that we're going to be reviewing is compliance and regulatory questions. And this tests your knowledge on things like Medicare, the different parts of Medicare, payment policy, fraud and abuse, HIPAA, ABNs, things like that. So in this section, there are 18 questions. There are 7 coding guideline questions. There are 3 compliance questions, 4 medical terminology questions, and 4 anatomy questions. So we're going to look at some samples of those and have you answer them in the chat box, and I'll be timing you. There are some questions that will take you less than 2 minutes and 40 seconds, and there are going to be some questions that'll take you a little longer. So for those of you that took the course, in chapter 1, there are these rules and setting the stage as to patients having different types of insurance. And the insurance categories are either private insurance or government insurance. And there's some samples there of what's private and what's government. And there might be some self-pay patients as well. So that's rare that you'd have a self-pay patient. The course covered the different parts of Medicare. So you could get a question about, give you an example of a patient's care and ask you if that would be covered under Part A Medicare, Part B Medicare, etc. Part B Medicare is the professional service portion that the CPC deals with, and that is your physician professional services, no matter where those services are rendered. Part A is inpatient, that covers the hospital stay. It covers the nursing care in the hospital. It also covers some other things like dialysis treatments. And so C is what we call Medicare Advantage, and that's when a patient joins an HMO. They're still Medicare, but they're giving up their fee-for-service Medicare to join a group to take care of all of their medical care. It's less expensive, and they don't have to worry about deductibles. But they are then limited to that facility, that organization, to get all of their care. And then Part D is drug. So they expect you to be able to know what the parts are. Another important part in the compliance and regulatory section is the medical necessity. And this is for what was given to the patient. Is there a good, solid medical reason for it? For example, if you do a chest x-ray, you don't expect your diagnosis to be diabetes or contusion of the foot. You expect it to be something about bronchitis, pneumonia, asthma, maybe tuberculosis, a diagnosis that makes sense. And so all payers don't pay everything, or insurance payers, including Medicare and Medi-Cal, they don't pay for everything. So a doctor just can't say, I wanna do all this genetic study on this patient, and then I want every bone x-rayed and every lab test done that they possibly could. That can't be done because it won't be paid. So the testing that is ordered, the treatment that is given needs to be documented and noted as necessary for that care, as is what is established good medical practice. Insurance companies publish what they pay and what they don't pay. So for example, they'll say, we'll cover a XYZ lab test once a year for the patient if they have this diagnosis. We'll pay it 3 times a year if they have this diagnosis. And that's hard information to get to. But on the test, they expect you to know what medical necessity is and how to identify it and communicate it. For Medicare, there are these national coverage determinations and local communication. LCDs are the local coverage determinations. The NCDs are the national ones. So everybody across the nation has the same testing and treatment diagnosis requirements for treatments to support medical necessity. And then locally, our MACs are independent Medicare administrative carriers, and they process the claims in certain regions. So for example, in California, we have Noridian that pays and processes our claims. And regionally, they can set certain tests and treatments that require certain diagnoses in order to be paid. And doesn't mean the patient doesn't have or need, or the patient can't have that treatment or that test. But if the giver of that test or treatment wants to be paid, they're going to have to sign an advance beneficiary notice. And there may be a question about what is an ABN. And so this is a form that is signed by Medicare patients prior to treatment or testing performed that is not going to be approved, that is not deemed medical necessity by Medicare or medically necessary. And how do you know that? Because you look at the CPT codes that you're going to be billing or coding, and you look at the ICD-10 codes for that, and there's a list. And if it's not on the list, it's not covered. And you have to let the patient know. And if they still want the test, they can refuse it. They have to sign the ABN. HIPAA, make sure you read up on HIPAA. HIPAA from 1996, and we tend to think that it's only about privacy, but it is about electronic transactions and code sets, so that we only use the ICD-10, we only use CPT and HCPCS to submit our data. And of course, MPI numbers, and but we normally talk about and have issues with the privacy and security of that health data. And here's some abbreviations and stuff. Most of you probably are well aware, because if in the medical facility, we're trained every year on HIPAA. And then high tech strengthen HIPAA by making sure that our EMRs have audit trails, who's in the system, looking at the file, do they have authorization to do so, etc. Office of Inspector General protects the is under the Health and Human Services umbrella, and they publish a monthly work plan that we can go in and look at to see what they are going to be auditing, so we can be prepared. So the work plan. They do publish a OIG compliance plan, and these are the 7 steps to an effective compliance plan as listed by the OIG, the Office of Inspector General. And you can just Google OIG compliance plan to get a copy of this. And there's different plans based on the type of facility. Like there's one for SNF, there's one for billing companies, and this is the one for doctors' offices, so that they can create their own plan on being compliant. You know, being compliant is a constant battle. It's not a plan you put in place and then just put on the shelf. You have to, should be a live document, and you do the best you can. For example, where it says conduct internal monitoring and auditing, you have to decide how you're going to do that, internally, externally, how often. It depends on your practice and your ability to do that. So, but this is the expectations. You might get questions about reviewing operative reports, and this is again in chapter 1 of your textbook. And this is about, you're looking at main points. And at the end of each section of the surgery section in your textbook, there are sample operative reports that you can review. Okay, so that's just highlights of the things from the compliance section. And just a reminder, we want you to listen, learn, work through the exercise as best you can, and then indicate your final answer in the chat box. You want to try to eliminate answers first, and you won't have time to check each one on the real test. And the exam determines this: can you code? That's what the exam is trying to look at. Are you able to code something? And can you understand the language? Can you read and comprehend the parenthetical notes? You know, those notes in the coding books that are in parentheses underneath codes or in the notes section on the pages. Are you able to read and comprehend those and understand the guidance that is given in the coding books? I believe you're ready to sit for the test when you're able to complete 25 questions per hour with at least a 70% accuracy rate. You know, that because that's what the test expects. On the exam grid, so you're going to be given a booklet and an exam grid, and the answers need to be on the exam grid. You'll bubble them in. There is rows, and so I forgot how much is on the row, but it's like an hour for each. If there's 4 rows, then you want to have an hour for each row. So 25 per hour. And that's just a guesstimate in order to get them all done. Again, some questions will take you longer than others. All right, so here are your first 3 questions. Okay, so in the chat box, for those of you that are playing along, you don't have to. I'm not going to, you can write just on a piece of paper in your own mind, for your own self, and then check the answers that I'll be given. And go. Go ahead and start. All right, let's see. We already have someone that has answered all of them. It's good timing. And I answered a few questions that were in the chat while I was out there. Okay, so the first one is D as in dog, the pulmonary vein. So this is a question, an anatomy example of an anatomy question. So you should know the flow, the flow of blood in the body. And there's a good picture in ICD. So know where those pictures are. You can also put a step-by-step of the flow of the blood flow in case you get a question. Okay, so number 2 is C. Number 2 is C. The mediastinum contains all the following except. This is a type of question that gets missed a lot. It might not be the mediastinum that you are asking for, or the question, it could be in the thoracic cavity or in the upper respiratory system. These organs, which organs are not there? So it is, again, an anatomy question, and you can just look at your anatomical plates in ICD to determine it if you're a little bit unsure. If you're sure, that's good. And so number 1 is D as in dog, number 2 is C, and number 3 is also C. And you can be able to see this by just looking at a picture of a lung, either in CPT or ICD. And the reason why is because the one with the 2 lobes is the heart is tucked right into there. And so the right lung is going to have the 3 and the left is going to have 2. All right, let's do some more. The root word for mouth is, and the surgical procedure, and splenorophory. So let's go ahead and have you do those. Okay, we've got our first answer, so we'll go ahead and look them over. So the root word for mouth is stomato, C. So a question like this, if you really think about it, it actually is hoping that you know all four terms. And so glosso is tongue, for example, bucco is cheek, and D is teeth, so stomato. So that is the root word for mouth. A lot of people think that's related to the stomach, of course, because that's what it looks like. All right, so the first one is C. Number 2, so you're creating an opening into the jejunum. And so here the answer is jejunostomy, creating an opening, ostomy. And it's kind of interesting if you look at all of these answers. This is pretty an easy one because jejunum is right in the beginning here as a term. And the splenooraphy, or splenography, is a suturing a wound of it's B here. So rage is going to be hemorrhage, softening is going to be malacia. And to answer these questions, you need to be able to, you won't have your textbook, you just have the 3 coding books to answer these questions. So in the CPT book, in the Roman numeral section, there are some very main terms, subterms, and you can go there and write some more in that you might think that you might forget. You also could have a page of them if you really need to, but only write down the ones that you don't think that you can remember. All right, here's some sample compliance questions. Now, these are just samples, and so let's see what you come up with. Okay. Okay, let's see what we've got. These are the type of questions that you're really not going to be able to use coding books for. So you should have a page somewhere in your book where you have some basic questions about the HIPAA, because that's not going to be in any of the coding books. So the first one is D as in dog. And so every health plan is required to be a covered entity. Every medical facility is considered a covered entity, but workers' comp is not. It is on its own. So they didn't have to go to ICD-10. They don't have PHI or any of those requirements that, although they do follow them, but they don't follow necessarily the rules that we have to follow as a covered entity. They don't have to worry about high tech and things like that. Okay, so D is in dog. And number 2 is C. They publish a work plan every year and what they're going to be auditing for the following year so that we can get prepared. And number 3 There are 7 components included in the effective compliance plan. All right. All right, so here's a sample of some coding concept questions. Okay, so let's have you answer those. All right, we already have someone that has the answers. Okay, so that code next to the main term is called the default code. For number 2, the only way you can answer that question, I think, unless someone has a better idea, is you have to look each one up in the tabular index to see which code contains an instructional note that the 2 can't be related to occur together. So that would be an exclude note. And so in that, you'd have to look up each one in the tabular index. And that answer is B as in boy. And number 3 is also D. Section 4 is for diagnostic services only in an outpatient setting. So these are the guidelines. When you're working with the guidelines, already I hope you have in your mind, because some books have guidelines in the front and guidelines next to each chapter in the tabular index. So which one are you going to be using? If you're using the one in the front, make sure that you highlight each of the chapters so that it's easier for you to thumb through it. So if you're looking for chapter 10, for example, you can see each chapter highlighted and turn the pages more quickly rather than looking for it, because it is a finer print and the fonts don't seem to differentiate a lot between one chapter to another. At least it's hard for me. So I just go through and highlight where it says chapter 1, then chapter 2, chapter 3, and chapter 4. And that way I can get to the chapter as quickly as possible if I have to look up a guideline. Someone asked me the other day, how realistic is it that I go in and look for a guideline? Well, it depends on how quick you are at it. If it takes you 10 minutes to look at a guideline and read a guideline, that's probably not great. And so you have to determine how you might answer that question by ruling out 2 things maybe that don't make sense in the answer, and then trying to do the best of the other 2. but you should practice being able to get to these guidelines quickly. And they will give you guideline numbers in questions. And when they give you the guideline number in a question, you should be able to turn to that quickly. So practice that. All right. So here is the ICD-10 section. And here are some tips for success in this section. To make sure that you understand that there are guideline questions that could be in play here, or just straight coding questions. Make sure a lot of the questions are about the exclusion. So you got to look at those tabular notes. You have to verify. Pay attention to the details in the question. Like, for instance, which one is not? Which one is? So when you're reading the question, underline some main things that you want to remember. The last thing you want to do is keep reading the question 2 or 3 times. You want to be able to read the question once, and as you read, underline what you think is most important in the question. And again, careful where you place your notes in the coding books. If you have notes all over, you're going to be lost. In fact, I've several students have told me that they just couldn't find where they put their notes. They couldn't interpret their notes in some cases. So be careful where you place your notes, and remember, a note is there to jog your memory, so you need to be brief. Your notes are personal. What I write is going to be different from necessarily what you write, for example. Okay, so you recall the ICD-10 layout, and they expect you to be able to understand the book cover to cover. And as I remember, as the guidelines are in the front, and some of you have them in the back as well, and you're going to choose which one you're going to be using and stick to it. In the table of neoplasms, if you turn to the table of neoplasms, one thing that I think that most students forget, if you turn to the first page of the neoplasm table, and there's a lister there, and the first main term says neoplasm, neoplastic, and the malignant primary is C80.1. This line here is for when you don't know where the cancer is. There is also, you can find that same number under neoplasm undetermined. So the primary, sometimes the patient comes in and they're far advanced, and they are working with cancer of the lung, but that's not the primary spot, but they don't know where the primary spot was or is. And so this is the column, or the section for when it's undetermined where that primary spot is. Another thing that I'd advise you to do is read the box that is above that. Many of you forget that these are instructional notes, and highlight what you think is important to you. So I'm sure you all know the difference in the columns, and I'll just highlight and remind you the difference between uncertain behavior and unspecified. Unspecified means the doctor didn't chart it. Your provider did not chart the behavior. The uncertain is where the pathologist or whoever's reading the sample or interpreting the sample is looking at it but can't tell. And so they will say, it could be this, it could be that. I can't really ascertain what it is, and I need to send it to another specialist to read. That would be uncertain. So there's a little distinction between the two. And so you want to remember that. In pathology, there are pathologists that are specialists in different organs and well known for it. So there's a kidney specialist. So if a pathologist is looking at a kidney sample and can't really determine what it is, they'll send it to that kidney specialist at Mayo Clinic, for example, in Minnesota, or someplace in Stanford. That person, that's the expert on kidney diseases for pathology. So that's the different columns. In situ, I get that question a lot. In situ means confined to that body area or in that cavity. I look for the documentation that says in situ in order to code it in that column. The table of drugs and chemicals is a section normally requires 7 characters. They start with T. You look it up by drug name. You can notice that it starts with numbers because this is chemicals. And so you would just look it up here. And again, these are different columns to determine the different scenarios. So one of the columns is adverse effect. An adverse effect is when a drug is correctly prescribed and properly administered, but the patient has an adverse effect to the drug. So for example, a lot of times kids take erythromycin, you know, that pink medication you keep in the refrigerator for earaches. But some kids develop a rash when they take it, or diarrhea. So that would be, if it was correctly prescribed, you take a teaspoon every 4 hours and you're administering it correctly and they develop a rash, then that would be an adverse effect. And then we're going to talk a little bit about coding adverse effects versus poisonings. So I might as well talk about it now. When there's an adverse effect, you code first the adverse effect. So you would code the rash, and then you would code secondarily the drug from the drug table. So the adverse in the adverse effect column next to the drug would be your second code. Whereas if the patient has an overdose of something, a poisoning, the poisoning code goes first, and then they develop vomiting. So there are, depending on whether it's an adverse effect or a poisoning, what you code first is going to be important. Hey, the external cause codes. You're only probably going to get one question in this section. I don't know why they test us on these, because we don't use these in the outpatient world. Trauma centers use them, and hospitals use them, but the physicians normally don't use them. And they're never, the things you need to remember is they're never primary. So they're never in the first spot. A lot of times I'll get a diagnosis from a physician that'll say needle stick, and they'll give me the W code. Well, it's not a needle stick. It's actually an exposure to bodily fluids is the primary diagnosis. You can't use these W, X's, and Y codes as your primary diagnosis. There is a hierarchy to using them, and I'll show you an example when we get to them. But big thing is they're never primary. So if one of your examples shows these codes before your primary diagnosis, you know that would not be the right answer. So you'll want to know where the guidelines are. They're going to list them as 1A something, and you'll know how to get there. And here's referencing the guidelines. And then in the guidelines are questions like NOS. What does NOS mean, for example, or what does NEC mean? So those are common questions that are asked. Just make sure that you are able to get to it and you understand how to code those. See how it says these are parenthetical notes here with the parentheses, and you either use them or lose them. And then here is NOS, not otherwise specified. So not otherwise specified means that in your chart it's not, it's the equivalent of unspecified. No further reference as to what the degree of the illness. So this is what they might give you. So they might give you a question and they'll say, as outlined in 1C4A2, and so you should be able to get to section 1 in the guidelines. Then C are the chapter specific guidelines. B are the general guidelines, and so C are chapter specific guidelines, and then 4 are the endocrine, A is diabetes, and then here it's about the type of diabetes not being documented. You don't always have to look it up. Some of them make sense to you. For example, if you remember that if the type of diabetes isn't documented, that you default to type 2, you don't need to look it up. Answer the question and move on. Have the confidence. I know that it's hard to. You want to be 100% sure on something, but in this test, you won't have time to look up every single answer and or take the time to necessarily be 100% sure. There are some things that they want you to remember, and that's why it's timed. And so this is what you'll find when you read it. So when you go to the guidelines, you're going to hopefully have a placeholder there for 1 and B, 1B, and then C. And then you'll be able to turn to that and read the guideline when you need to. In the ICD-10 section, there are 5 questions, and there are official guidelines as well. And you will also get CPT scenarios with ICD-10 codes. So when it says you only have 5 ICD-10 questions, it is just the ICD-10. It's not with CPT. So you'll get more than the 5 questions. Okay, so here are some. We're going to practice. Okay. And we'll time you. And first one, put the answer in the chat box. All right. That was a great timing on a lot of your parts. That's great. That's what you need. Some questions you just need to answer and move on. So this is a question to make sure you understand associated signs and symptoms with a final diagnosis. And so here she's got complaints of diarrhea for the past 4 days and also lower abdominal pain. And after examination, she was diagnosed with viral gastroenteritis and given some advice. So the question here is that the final diagnosis, viral gastroenteritis, if you know gastroenteritis is vomiting and diarrhea are the symptoms. Abdominal pain is also associated with gastroenteritis, and you wouldn't code them separately. If she also had leg pain, or she also had, trying to think, maybe shortness of breath or a rash, those might not be coded. Those might be coded separately because it's not associated with it. So they expect us to be able to know for some of the more common conditions what are the signs and symptoms and when you don't code them. So the answer is C. Most of you got that, which is great. Okay, and here is another one. Correct, Aurora. B, as in boy. This guideline is the maximum length of time to be considered acute, and it is found in 1C9. So another thing is, if you don't remember how many weeks for acute, you can at least probably know that D is not going to be the right answer. And maybe A is too short, so you're left with 4 weeks and 8 weeks. That's how you kind of look at these answers and rule 2 out. But this would be hoping that if they don't give you the guideline number, that you would understand that the myocardial infarctions are in the cardiovascular section, and that would be in chapter 9 in the guidelines. Okay, here's another one. All right, we already have an answer. All right, this is how you would answer this question. It's one of the more difficult questions, and will probably take you at least 3 minutes to do it if you haven't practiced the late effects on or this guideline in 1C9D. So here's the patient has a right-sided hemiplegia, so he has inability to move the right side and aphasia, unable to speak. And so the provider documents he has a current cerebral infarction. due to occlusion of the right middle cerebral artery. And so here's some of the lookups: infarction, cerebral, due to occlusion. And so you're going to find that, so this is because he has this from a previous CVA. So, right? So he was already had a cerebral vascular accident, which is a stroke. And so this is what he had before. But now he has a current cerebral infarction due to occlusion of the right middle cerebral artery. So he's having a stroke. These happen in the arteries in your brain. There's heart attacks that happen in arteries in your heart, and then there's strokes that happen through the arteries in your brain. So the first lookup is for what's happening today, and that's the infarction due to the occlusion of the cerebral arteries. And then you're going to code those late effects from the previous condition that the patient had. So the answer is C. And the when you're looking up hemiplegia or things that affect right or left side, there's a guideline that if you don't know if the patient's right-handed or left-handed, you're going to default to dominant for the right side and non-dominant to the left side. If you don't know if they're right or left-handed, a lot of times the documentation doesn't indicate that. Okay, here's another one. Okay. So in this case, we've got a couple of answers already, so let's review. Let's see what we've got. All right, Mona, good. So patient has a pressure ulcer. Pressure ulcers are decubitus ulcers, bed sores, and so eschar is the scar tissue, or the almost like the covering that happens from a burn. And so what happens with these ulcers is there's different stages. So you need to know the location of the ulcer and the stage of the ulcer. And so the answer is C here. And let's see how we got to that. So you need to identify the location of the ulcer. The ulcers are normally developed on the prominence, the bony prominences on the patient's body. So the ankles, the knees, the hips, the elbows. And so and the patient needs to be turned a lot if they're non-ambulatory, right? So the location of the ulcer is what you're going to be concerned with. And then the stage of the ulcer. Ulcers, there's some guidelines about ulcers healing during admission, and then ulcers evolving into a higher stage. So there are guidelines for that. But in this case, I'm going to go back to the scenario. The stage of the ulcer cannot be determined because of the scar tissue that is developing. And so what'll happen clinically is they don't want to so when a patient has an ulcer, sometimes it's very deep, but superficially you can't really see that because it's dying maybe from a lower level. And so it looks like it's viable tissue. So what they do is they clean out the ulcer, and then until they see bleeding. And when they see bleeding, that's viable tissue. When the tissue has died because of the ulcer, there's no bleeding involved. And so they have to clean all of that out. And then once they start to see the bleeding, then they go, okay, this is the extent of where the ulcer is. And now that I've cleaned it out, it'll start to heal in that area that's opened. And in that healing area, it's not ever going to be normal tissue again. It's going to be scar tissue that fills in that gap. But sometimes what happens is the ulcer is deeper and it is still dying. And so they don't want to open up some of the scar tissue unless it starts to become boggy or saggy. And that means that it might be still dying underneath. I hope I explained that correctly. But you're probably thinking, oh, you didn't need to explain that to me. Thank you. But the point here is that do you know what unstageable means versus undetermined? It's almost like that neoplasm question we went over that isn't documented or it needs more advice to send out for a consultation. In this case, the physician has documented that he can't determine the stage of the ulcer because of the scar tissue that is developing, the eschar. So that would be considered unstageable, not or unstable, not unspecified. All right, here's another one. All right, we have some answers. So let's look at this. So what happened here? The patient has respiratory failure due to incorrect medication being given to them. So Valium was administered instead of Xanax. So look at your scenarios here. It's a sequencing question. Does the respiratory failure go first, or does the poisoning of the drug go first? That's the question, really. It's a sequencing question. And the answer is C. The patient was not given the correct dose of medication or the correct medication. This is a poisoning. And in the guidelines, 1C19 here, it indicates that errors made in drug prescription or administration of a drug by a person you would code it as a poisoning. So the T code goes first, and then the condition or the manifestation. So the accidental poisoning goes first, and then the respiratory failure goes second. It's not an adverse effect, it's a poisoning, even though it's not, I'm going to say, intentional. It was accidental, right? At least I'm hoping it was. So sequencing, very important to understand for the drug codes. All right. So that is the review of the ICD. And again, I'll send you all these questions. No worries if you want them. Just let me know. And we'll move on to CPT. So I'll give you a second to pull up the books. And we'll take a break in about 10 minutes. So be able to let you get another cup of coffee, some water, stretch. All right, we'll start with CPT. So there's going to be only 3 HCPCS questions, not a lot. And so we're going to review HCPCS and the surgical guidelines. Surgical guidelines can be found on page 72 of the 2023 CPT book. I love when I teach out a CPT because I can just give a page number, which I can't for ICD because there could be people with different books and different years of books. But if you have an older version or the newer version of CPT, you're looking for the green section right before the integumentary section that has the surgical guidelines. Okay, so let's look at some questions that could come through with HCPCS. Most of you know how to work your HCPCS book, small little book, expensive little booger, isn't it? All right, how often are HCPCS updated? What do you think? Yeah, quarterly. You're right. They're out. So you're going to say, well, wait a minute. I purchased this book once a year. You know, why are they updated quarterly? So this is one of those areas where they're going to publish them on the internet, and you're going to be able to get onto the CMS website and be able to look at the website to see what's updated. And once it's published quarterly, then it goes into effect the latter part of the year, and that those instructions are there. So you might in your HCPCS books, you might want to write somewhere in the very beginning of the pages, updated quarterly. I can't find it within the book, at least the book that I'm using, but maybe in the AAPC book for HCPCS, they do indicate there in the foreword that it's updated quarterly. Okay, so how about this? Someone should have had the answer. Okay, good. All right, they've got some answers here. So one of the things is that in the HCPCS books, there is an abbreviation section. So you want to mark that. Hopefully it's there. Also in CPT, there is an abbreviation here as well. but neither of these are there, so you'll want to indicate if it's not where you're going to look for your abbreviation. So the answer is D, as in dog. But there is an appendix that lists the abbreviations and acronyms and their meanings, and you want to look for that in the HCPCS book. IT stands for intrathecally. So it's a route where a drug is introduced into the spine, into the subdural space of the spine. So IM is intramuscular, SC is subcutaneous, INH is inhalation through the nose, through a IPPV treatment would be C, and D is through the spinal cord. So a lot of people think, oh, D, IT, that's somebody that works on my computer. But yeah, the answer is D, as in dog. And I introduced this question just to make sure that everybody knows that there are two places to find abbreviations, back of CPT and in your HCPCS, and you can add things there. That would be the logical place where you should find all of your abbreviations, especially those that you think you're going to need. Okay, let's look at the surgical package. So here, anytime you have guidelines before a chapter, it's important to read through them and understand them. And so it indicates that what is included in the surgical package on page 72, the office visit before and after surgery, numbing the area. Remember that a surgical code is anything, and I'm going to write this in the chat box. A surgery code is any code that begins with a 1, 2, 3, 4, 5, or 6. And that means that anything that begins with a 1, 2, 3, 4, 5, or 6 follows these basic guidelines. So it's important to differentiate between a surgery code, an E&M code, for example, a radiology code, a lab code, because those are not going to follow the surgery guidelines. So we know each one of those numbers is going to be a different section in CPT and surgery, but those are considered the surgery sections. And so post-operative visits and things like that. Post-operative visits, there's published guidance as to how many days you would not charge a patient for follow-up, but there are exceptions to that. So it really is normal post-operative care is not covered. And in some cases, patients might need a week or two more or a week or two less. And so you don't want to code for anything that is normal post-operative care. And there are published post-operative dates on the CMS website that you can get. Used to be published in CPT, but it no longer is published there. And the surgery guidelines are for any surgery done in any location. So some of them are very minor that are in the doctor's office, and some of them are major in the hospital or in a ambulatory surgery center for some outpatient work. And then here's where everywhere in your book you indicate what all is included. And so you could have a question that talks about which one is included, which one is not included, what example would you charge for this example? And then you would say 0 because it's typical post-operative follow-up care. The typical follow-up or the post-operative days is 1 day major surgery. Well, it's a 90-day. And then minor surgery is 0 to 10. For HCPCS, these are, each publisher is different. Here's some more information there about HCPCS. Looking up drugs. And then your modifier. So, modifier 22, the biggest error that's made with modifiers is putting the wrong modifier on the wrong type of code. So 22 says increased procedural service, so you wouldn't use a 22 on an E&M, for example. 24 is unrelated E&M, and so this would go on the E&M service and not on maybe some other service that makes sense that says E&M. And so this would be during the post-operative period. You know, patients could be coming in with additional complaints and concerns that are unrelated. So all of a sudden the patient has, you know, like flu symptoms, for example, or headaches or dizziness or whatever it might be. And you have they're coming in post-op for an appendectomy. And you do the physician does the examination and determines the patient has gastroenteritis, for example, or flu. That exam needs to be documented, what organs, what systems he questioned, which areas he examined, and his final diagnosis, and anything that they're given as a plan and an assessment, and they can charge for that office visit. But unless you add a modifier 24, you will get denied for that service because it's during the post-operative period. So it overrides the post-operative service. And the service needs to be significantly greater than what is typically required. Like if he just looks at the patient and says, well, you probably just have a cold, just take Tylenol. That's not going to warrant an additional office visit. And some things are minor. Some things are minor, and the physician isn't going to do a lot of documentation, and he doesn't want to add another service. Some physicians are really, I don't want to say paranoid, but conservative is a better word for it. Conservative, and don't want to code for something or bill for something like this that might trigger an audit. They're very cautious and conservative about it. But really, if they document it properly, they can benefit from doing an examination separate and apart from the post-operative period and get paid for it. And here's a modifier 25. Again, this is when you're doing a procedure on the same day, and 25 goes on the E&M code, not on the surgery. 57, when you're doing surgery, if you looked at the guidelines, it said the day before is considered part of the surgical package. But there is an exception. What if you didn't have a chance to examine the patient before you did surgery? So what the normal scenario is, let's say you go to your GP and you have abdominal pain. They send you to the surgeon because you have gallstones. You go to the surgeon, he examines you, and he says, yeah, you need your gallbladder out. We're going to schedule it in 3 weeks. Okay, he is able to bill for today's visit, code for today's visit. He's examined you. The day before the surgery, you come in to the office, you get your paperwork, you might see the nurse or the doctor to make sure that you're ready for the surgery, and that visit is not payable. It's not codable because it's the part of the surgery to get you into surgery. But what if you go into the emergency room and you have abdominal pain and it's determined that you have an acute appendicitis and need your appendix out? The surgeon didn't have the ability to examine you and get you settled. So they can charge for the consultation or the exam the day before when they have not treated you for that condition. And so the 57 is the decision for the surgery that goes on that E&M code, and it overrides the preoperative visit, because you never had a preoperative visit to take advantage of. So 57. And so these are other things, 58, staged, you plan to do a second procedure, 78, return to the OR unplanned, or you return unrelated. So unplanned, meaning that you had a DNC and now you're hemorrhaging and you have to go back. The 79 would be, let's say that you had a fracture of your arm and you had some pins in your arm, and then you're home, and a week later you fall, and now you have a fractured ankle. Then you go back in with a 79 because it's unrelated. It's not the arm, it's the ankle. So as you break it down, it makes sense when you use these. And these are pretty self-explanatory, I think. The one thing I'll say is that in a reduced service, it is less than what's published. So if it says bilateral eye and there isn't a unilateral code, then you only were able to do one eye for whatever reason. Maybe the patient's blind in one eye, maybe the patient is uncooperative, then you would use a reduced service. 53 is a discontinued procedure, which means that the procedure, the surgery has to have started. If the patient is in the operating room and the anesthesiologist starts the anesthesia, and then they start to develop hypotension or hypertension, and they cancel the surgery, that surgery didn't start. So the surgeon can't code his CPT code for the surgery with this modifier because the surgery didn't start. But if he's in the middle of the surgery, or he's already started the surgery, and the blood pressure goes too low or too high and they have to stop, then you can code the CPT code for the surgery with the modifier 53. Modifier 59 is a distinct procedure service. So you do this, something on the left and the right, or you're doing two things on the left that are separate and apart from each other. Sometimes you're doing surgeries that are totally unrelated. It's not like a primary or a secondary situation. And then you can use a modifier 59. Most of us use this though. CMS provides a subset of modifiers to distinguish the certain circumstances for the 59. So a separate encounter, a separate structure, organ system, separate doctor, or an unusual situation. So I love these more than the 59. The 59 is just could be left to interpretation. I get a lot of returns for modifier 59 for better explanation. So if they are, if the carrier accepts the X codes, then you should use the X codes. You'll get the a better return for them and not a rejection for more information. And these can be found on the NCCI edits on modifier 59. And here's some more. And then these modifiers, the technical and professional component. And this is the breaking down of a service that, like an X-ray, where one entity is doing the taking of the radiology procedure and another, your provider is actually reading the study and diagnosing it. And then that would be a TC and a 26. Most of you, I think, understand that. Okay, so we're going to take a 5-minute break, and then we'll get back with the integumentary system. If you have any questions, put them in the chat box and I'll look at them and answer them as best I can.